And just by introduction, I do know at least some of you, or perhaps many of you on the call, I'm the director of the Cardio-Oncology program at McMaster University in Canada. And so, we try to advance our slides. Here are my disclosures. And so what we thought we'd do is just present three real cases of trastuzumab-related cardiotoxicity, run over some of the evidence to inform the management decisions that we take into consideration when we see these sorts of patients, and then discuss the remaining evidence gaps. And all this should take, I think, just over half an hour and hopefully leave plenty of time for some conversation. So the first case will be kind of familiar to everyone, really. A 56-year-old woman, right-sided early stage breast cancer, hormone receptor negative but HER2 positive, gets treated reasonably conventionally at our institution with surgery, dose-dense ACT, including doxorubicin, and then followed by 4 months of Herceptin. Her baseline LVEF was 58%, but then was referred to our cardio-oncology service when the EF was noted on surveillance to have fallen to 45%, and she was asymptomatic. And this question we see frequently is what to do with the Herceptin. Case 2 I've slightly embellished, but we've had a couple of cases like this, which is nearly essentially identical, with the one exception that by the time of referral, case 2 actually already had moderate to severe functional mitral regurgitation. And so I think we'll discuss some of the consequences or sequelae of this slight distinction a little later on. And so this is some work actually that a colleague of mine, Peter Soltis, undertook many years ago when I was in Australia, back training under Danny Cekic, who I'm glad to hear is on the call. What Peter did was injected anthracycline into the coronaries of sheep, and this is what happens. You can see that there is a clear dose-related myonecrosis that's very evident and very severe when there's a high concentration. And this is unsurprising, I think, to everyone on the call, and it's widely known, but I don't think that a conversation about Herceptin would be complete without understanding this kind of pathology. And again, it will be unsurprising to folks on the call that there is a relationship between the cumulative dose of anthracycline to which one is exposed and the lifetime incidence of heart failure. And this is a somewhat old slide now, but there must be millions of individuals and millions of women worldwide who've now received anthracycline. Now, onto the main course, I guess. We all know that trastuzumab is a life-prolonging drug. This is a pooled analysis of 5 randomized trials comprising nearly 2,500 patients with breast cancer, showing all-cause mortality rates. And you can see here in these randomized trials that the use of Herceptin reduces mortality rates there in the sort of mustard-colored curve by about 32% over the course of 8 years. So this is a substantial beneficial effect that we see there. Now, this is a somewhat old slide and classification scheme again, has had its critics, but I think it's still useful to help conceptualize the distinction between anthracycline-related damage that you see to the myocardium and trastuzumab-related damage. As we know, as we've described, anthracycline causes injury in a dose-related manner, whereas Herceptin seems somewhat more idiosyncratic. We've noted the myonecrosis and vacuolization that you see with anthracycline, whereas with Herceptin, you don't tend to see that. Rather, you see some ultrastructural abnormalities by electron microscopy. And so the anthracycline damage that's been described tends to be somewhat more refractory to reversing with medical therapies, whereas with Herceptin, we feel as if there is a higher likelihood of recovery, and we'll show you some data to speak to that. So this is one of the seminal anthracycline trials where women with early stage breast cancer were randomized to 3 arms, one arm containing Herceptin but no anthracycline, the second arm with anthracycline but no Herceptin, and the third arm with both. And you can see the LV ejection fraction over time there on the vertical axis. And I think this is a very nice physiologic demonstration of the pathologic changes we mentioned a couple of slides ago. In that, if you look at the top curve there, the group that received Herceptin, there is a dip in LV ejection fraction. But then from about 12 months on, after the Herceptin is complete, LV ejection fraction essentially returns to baseline, consistent with the fact that there is no myonecrosis. In the anthracycline group, you see a similar dip in ejection fraction, but unlike the Herceptin arm, the LVEF never returns to baseline. It only recovers or maintains a level that is imposed by the subclinical necrosis that's caused by the anthracycline. And in the bottom curve, when you get the combination of the two, we see a more profound drop in LV ejection fraction. But after the Herceptin is complete at 12 months, you see that the ejection fraction can only return to a ceiling that's imposed by the necrosis that the anthracycline has caused and left behind. So I think it's important to understand the absolute event rates in this sort of population. This is data from the same trial by Dr. Slaman, showing that in the group that received anthracycline, there was just over a 10% relative reduction in LV ejection fraction, and this was nearly doubled if you received Herceptin as well. But what I think I really wanted to point out is that the incidence of clinical heart failure in this well-conducted trial was in the Herceptin alone group, not particularly high at 0.7%, arguably, and obviously double that when in the Herceptin plus anthracycline group at 2%, but that there were no cardiac deaths experienced. And I think the point here is that while we frequently see reductions in LV ejection fraction, the occurrence of clinical heart failure is uncommon and cardiovascular death is very uncommon. So here are Canadian guidelines, and I apologize for presenting these in a truly Canadian way. Canadians are very apologetic folks, I've come to realize since moving here from Australia. So rather than present US or other guidelines, I've presented the local ones here. They're somewhat old, 2008, but they're still current. And they are really based on the protocols that were instituted in the sorts of registration trials that led to Herceptin coming on the market. And again, this will be familiar to most of you, that if you get an asymptomatic decrease in LV ejection fraction, typically one would continue Herceptin until the LV ejection fraction fell below the lower limit of normal, or unless there was quite a substantial fall in ejection fraction compared with baseline. Importantly, these guidelines, as the clinical trials did, recommend that if the ejection fraction reaches this threshold, that Herceptin should be withheld and ejection fraction reassessed after 4 weeks. And if it fails to recover, then Herceptin should continue to be withheld, and perhaps if it persists for a couple of cycles like this, should be permanently discontinued. And so that we think was a standard of care, and this is the recommendation given on the product monograph for Herceptin, at least in Canada. But I think that it's important, well, folks have started to consider whether we can therefore get away with shorter durations of Herceptin if it's understood that it can cause a fall injection fraction in a substantial number of recipients. And so this is a fairly recent meta-analysis of all of the randomized trials comparing 1 year's duration of Herceptin with shorter durations, and the bulk of these participants received 6 months in the shorter arms of these trials. What you can see is that when you pull the results, and it does include the findings from the Persephone study, that there is a 23% increased risk of death and 20% increased risk of death or disease progression or recurrence in the group that received less than 1 year's therapy with Herceptin. And I think this is a profoundly important piece of evidence, because it tells us that if we want to discontinue Herceptin prematurely, that the risk of death or disease progression or recurrence is real, and that there may be significant consequences for these sorts of management decisions. So our approach in Hamilton, and be interested in hearing about folks' approach elsewhere around the world, was in the absence of great evidence. When we saw patients referred to our clinic like case 1 or case 2, we'd present evidence like this and really ask the patient and engage them to see what their wishes were and what their preferences were. And I don't think it'd surprise anybody on this call that the vast majority, in fact, virtually all of the first 20 or so patients we saw in our service like this actually said that, no, I want to continue with the Herceptin if at all possible. I don't want to have it withheld with the chances of having it discontinued unless it's absolutely necessary. And so, of course, we obliged, and we've now gone on to publish our retrospective evidence from the first 20 or so patients who adopted this approach. So you can see on this slide here, echo number 1 is the baseline ejection fraction in our population. Echo number 2 represents the EF with which they were referred to our clinic. And these 20 or so women, they continued with their Herceptin as per their original treatment schedule, but with the addition of ACE inhibition and beta blockers and close surveillance in our cardio-oncology service and with echo. And what you can see is that the ejection fraction didn't continue to decline, and if anything, returned somewhat more towards the baseline ejection fraction, although not quite reaching there. So based on this, Carly Barron, who's now an oncology fellow at UHN, but was with us at McMaster at the time, published our approach to treating these individuals with LV dysfunction on Herceptin. Essentially, if systolic blood pressure is at least 90 and a heart rate at least 55 with no contraindication to ACE inhibition or beta blockers, we'll initiate a drug like ramipril and another like carvedilol or bisoprolol at low doses, understanding that most of these are otherwise healthy women and therefore tend to have somewhat lower blood pressures. We tend to stagger the introduction of ramipril or an ACE inhibitor and the beta blocker so that we avoid first dose hypotension. So we'll tend to stagger it a few days apart. And then every 3 weeks or so, we'll see them and up titrate the dose to the maximum tolerated. And while I say that the target is the maximum sort of recommended dose, the truth is we actually often don't get there, given that these patients' blood pressures tend to be on the low side to start with. Now, at about this time, the folks, Anna Barak, who will be familiar to many of you, and the folks at MedStar were conducting the SafeHeart trial. And this, again, I'm sure will be familiar to this audience. This was a single-arm prospective trial that recruited 30 patients with any stage of breast cancer who received trastuzumab in one form or another, and including trastuzumab and tansine there. They recruited individuals with an ejection fraction of 40 to 49%, and they all received a beta blocker plus renin-angiotensin inhibition. And what they found was that during follow-up, 3 of the participants, so 10%, exhibited a decline in LV ejection fraction of at least 10% or to an LVEF of less than 35, or indeed clinical heart failure. And quite concurrently, we were conducting the SCHOLAR trial in Hamilton. So this, just purely by coincidence, was a very similar trial. It was a prospective phase 1 single-arm study. We did not include patients with metastatic breast cancer, so only stage 1 to 3, but very similar inclusion criteria to SafeHeart otherwise. Again, all patients received, all participants received a beta blocker and an ACE inhibitor or angiotensin receptor blocker. And we defined a cardiac dose-limiting toxicity as a composite of cardiovascular death or an LVEF of less than 40% if there were heart failure symptoms, or an LVEF less than 35 under any circumstances. So this is the characteristics of our cohort. We had 20 participants. You can see the mean age there, largely Caucasian. Blood pressure was actually on the high normal side, if anything. Heart rate you can see, and a fairly typical smattering of cardiovascular risk factors that you might expect in a middle-aged female population in North America. This graph shows you the changes in LV ejection fraction from enrollment up to the final echo included in the study at between 12 and 24 months, by which time the LV ejection fraction had significantly improved compared to the LVEF that they reported or recorded at their enrollment in the trial. I'm going to talk you through this slide because I think this is probably the most interesting piece of data we have from our trial. Each of these bars represents one of our participants. The blue part of the bar represents the number of doses of Herceptin that the patient received before being referred to our service and before being enrolled in the trial. And the red part of the bars represent how much Herceptin they got after enrollment. You can see that the target dose of Herceptin was 18, and the majority of these individuals reached that 18 doses of Herceptin, with a couple of exceptions. So participant 19 actually only reached 17, but that was by personal choice. Medically, she was actually fine to receive her 18th dose, but just felt like she didn't want it. But the other 2 patients are of interest here. We're going to, one of them was actually one of those patients, case 2 that I mentioned before, who actually had moderate to severe functional mitral regurgitation at baseline. So this individual had progressive deterioration in LV function, New York Heart Association class 2 to 3 heart failure, and had to be had her septum permanently discontinued. What is strange here, actually, in this slide set is I'm missing case 3, which I had intended to present before. I don't see the slide. I don't think we've come across it, so I'm not sure how it fell out, but I'm going to just present it verbally, I guess, for you now. Case 3 was intended to be a 34-year-old woman who actually was diagnosed initially with Lee-Fraumeni syndrome. So her story was that she was diagnosed with a breast mass, found to be a breast cancer, treated with Herceptin, and referred to our service when her LV ejection fraction deteriorated there. And so we initially treated her and enrolled her into the SCHOLAR trial. And she, over the course of this therapy, started to experience fatigue, her blood pressure increased, and she experienced a substantial weight gain over 3 months. Her ejection fraction when she first saw us and when she was enrolled into SCHOLAR was 46%, and it remained 46% after 9 months of Herceptin therapy. The global longitudinal strain, as you can see there, was markedly reduced. And I present this case because it was quite interesting in that it became apparent clinically as well as biochemically that her syndrome, including the Lee-Fraumeni syndrome, was a manifestation of Cushing syndrome. So you can see that at this point, her early morning cortisol was somewhat elevated, but her urine-free cortisol was profoundly elevated, and we found a significantly sized right adrenal mass. This was operated on and proven to be an adrenocortical carcinoma, and she did continue with Herceptin sporadically, but by 11 months, as her EF started to decline and she had heart failure symptoms, Trastuzumab was discontinued as per protocol, and her EF actually continued to decline to a nadir of 28% before ultimately improving over time. And she was one of the other 2 participants who failed to receive her full course of Herceptin that I showed you a couple of slides ago. So having presented, I guess, our experience and thoughts about how one might approach continuing Trastuzumab in cardiotoxicity, I thought we might just spend the last few slides talking about some of the remaining unknowns of this area. And I've sort of summarized my reflection of those points here. I don't think we know the optimal frequency or approach to either predict or identify very early the presence of Herceptin toxicity. I don't think we know the overall risk versus benefit, the risk-benefit ratio of continuing Herceptin when cardiotoxicity is manifest, like in all of the cases we presented so far. We don't know the long-term consequences, what happens after someone has had Herceptin toxicity, especially if we choose to continue it despite a reduction in LV ejection fraction. And the last question that we frequently get asked is how long should you continue cardiac medications if LV function recovers after Herceptin toxicity? So I thought the last few slides, we could just go through some of the evidence that helps to address some of these unknowns. So this is work from Dinesh's group in Toronto. Dinesh has done a lot of work looking at strain for the detection and prediction of cardiac toxicity. And in this systematic review, they found that a reduction in LV strain, and the cutoffs and vendors for strain are listed there on the right-hand side of this slide, is a very strong predictor of future cardiotoxicity, typically defined as a fall in ejection fraction that was fairly substantial. Individual trials were small and the confidence in limits were wide, but when pooled, reduction in global longitudinal strain was a very strong predictor of cardiac toxicity, as you can see from that pooled odds ratio of over 12 there at the bottom. I think it's fair to say, though, that how we incorporate strain into clinical practice still is somewhat varied, and obviously I think a point that we can discuss a little further. What this COVID-19 pandemic has forced us to do is consider more strongly, I think, than before, approaches other than echo or imaging to monitor LV function on Herceptin. And so this is probably the largest study from Dr. Key's group, largest prospective study, looking at the value of various blood biomarkers for detecting or predicting the future risk of reduction in LV ejection fraction. And what they found was that of all the biomarkers, and this is an adjusted model, NT-proBNP is the one that probably shows the most promise. What's notable though, is that for every doubling in NT-proBNP levels, so let's say you start off with 200 and you go to 400, the resulting fall in ejection fraction at the subsequent echocardiogram was only 0.7%, so pretty modest. And this tells us that you would actually need a fairly substantial rise in BNP to be observed to actually see a substantial subsequent fall in LV ejection fraction. So while I think this represents probably the largest cohort and sample to date, we still need some more evidence to understand how biomarkers might be incorporated, I think, into routine clinical practice, and especially to address the question, how does it alter your management? With regards to the risk versus benefits of continuing Herceptin once you develop cardiac toxicity, you know, I think that it would have been tempting, and we thought about it long and hard, do we just continue the sort of protocols we did for Scholar, the sort of protocols they did for SafeHeart in all patients? But I put it to you that I don't know that this is entirely satisfactory. So this is what I think we know, and what we don't know about this strategy has been described to me as plowing on with Herceptin despite manifest cardiotoxicity. We do know that there is roughly, between two studies now, a 10% incidence of cardiac dose-limiting toxicity, which is quite significant reduction in LV ejection fraction or clinical heart failure. We also know that these two studies are, in absolute terms, small with wide confidence intervals. And so what we don't know is whether the increase in Herceptin completion rates that we might observe with this strategy actually outweigh that 10% or so risk of early heart failure. Secondly, in the longer term, we don't know whether there is reduction in cancer recurrence or progression rates, and whether some gains here outweigh the long-term cardiac adverse outcomes from pressing on or plowing on with Herceptin in patients who've already exhibited toxicity. We've just received some really positive news that the Canadian Cancer Society, even in this difficult environment, have funded the Scholar 2 trial, where we propose to randomize 130 women with early stage breast cancer, much the same inclusion criteria as for Scholar 1, but this time randomize them to either standard care according to current guidelines, and as I outlined before, that would involve holding Herceptin if the LV ejection fraction falls, and then considering restarting if the ejection fraction recovers, versus a strategy of plowing on, as we said, as we did in Scholar 1, where we just continue Herceptin as per the original treatment schedule. All of these patients, as per standard of care, would get referred to a cardio-oncology service, and all of them would get an ACE inhibitor, ARB, and a beta blocker as tolerated. Our plan here was to follow them up for at least 12 months after Herceptin is complete, and the primary outcome would be the proportion of individuals who actually completed the original Herceptin schedule, and the co-primary safety outcomes are LV ejection fraction as a continuous variable and a composite of heart failure hospitalization or cardiovascular death. So we are in the process of submitting this for regulatory review and hope to initiate this study still within this calendar year if everything goes well with the pandemic. We don't know the long-term sequelae of Herceptin toxicity. There have been a number of studies looking more broadly at cardiotoxicity and its longer-term consequences. This is work from Hussam Abdul Qadir in Toronto, looking at the administrative registry here in Ontario, and comparing the incidence of heart failure late after a breast cancer diagnosis, so with a 10-year horizon in those folks who received either anthracycline and or Herceptin, compared with a control population, the Ontario general population. And Hussam found that, as you can see, a significantly higher rate of heart failure hospitalization in people who've been exposed to anthracycline and or Herceptin. Now, the numbers, I guess, for Herceptin are a little low to be able to tease out individually from this larger cohort. And so I think we still need more data to understand, especially what we're doing to these individuals when we continue Herceptin after they've manifested with cardiac toxicity. Lastly, I guess to try to address the question of how long do you continue an ACE inhibitor or beta blocker for once the LV ejection fraction has returned to normal. Again, I don't think there is great data from the cardio-oncology realm to address this, and so as we often do, we've extrapolated a little bit from other evidence. This is a study from Sanjay Prasad's group in the UK in England, and many of you might be familiar with the TRED-HF trial. It was actually a pilot trial, and hence only about 50 or so, 52 participants who had dilated cardiomyopathy, ejection fraction less than 40%. And after they had exhibited recovery in LV function, they were randomized to either withdraw this heart failure therapy or continue it. And what you can see is that the treatment withdrawal group in the red experienced a much higher incidence of a future decline in LV ejection fraction or elevation in BNP compared with the group that continued with their heart failure therapy. And so while this was only a pilot trial with small numbers, for me, this encourages our group to certainly advise patients, even though they've recovered from LV dysfunction from Herceptin, to continue with their therapies for an indefinite period of time, unless there's a very good reason not to. Obviously, those can include, side effects to which they tolerate poorly. But in general, we try to continue therapies in this population. So my final slide really is to conclude. I think it's fair to say that there's a paucity of data to guide us as to whether this strategy of plowing on with Herceptin when cardiotoxicity is apparent, whether that is the best thing to do. I think we've shown that it's certainly feasible, and patients are accepting of this strategy, and in fact, they often ask for it. But I think it's also fair to say that its risk-benefit ratio remains a little uncertain. And this should be evident from the fact that we're undertaking SCHOLAR-2, but I really think clinical trials to address this sort of uncertainty are necessary to move the field forward. And so that was the end of the presentation, and we'd welcome any discussion and comments.
Darryl, that was really excellent, and you brought up, I would say, a number of hot button issues. So I think, I imagine that many people on the call have opinions, and as do I. I certainly have opinions. But let me just pick one or two of yours, and then I think of the issues that you brought up, and then we can see where it all goes. But first off, the slide that you showed about the pathology findings in an animal model, one of your earlier slides, I think that one right there, that really does bring home the point that if you are sensitive enough in your detection, that any dose of anthracycline is likely to cause some damage. Now, most of the time, people have an otherwise normal heart, and they can handle losing a few myocytes, based on tolerance of anthracycline. But I think that this type of data really does show you that even one dose has the potential to cause significant myocyte damage. So I think that this is an important concept. I do think that anthracyclines have been given for so many years, and obviously people can tolerate it. But I would say, we were told, certainly in medical school, that, if you drink a certain amount of alcohol, you're going to lose a few brain cells. And that didn't stop you from drinking. You kept drinking because you figured you had some extra brain cells to give up. Now, when you get to be 65 and you start forgetting things, and maybe you rethink that one. But bottom line is, the bottom line is that this is a very important concept, and I think you presented it very well. It's the historical data about dose, 500 milligrams per meter squared, etc., is such an insensitive way of detecting heart failure because those patients had clinical significant systolic heart failure. That was their metric. In this case, you have a biopsy, which is obviously much more sensitive. So I think that in the clinical realm, we don't have a way of detecting that injury very well. And in the experimental realm, you could detect it very clearly. So anyway, that's one of my takeaways from this slide, and I think I'm really glad you presented it.
Thank you. I think that's a really valuable comment. I was wondering if I could just ask you then, what is your approach to identifying these sorts of individuals with subclinical damage? Do you use biomarkers, and how does it alter your management in the clinic?
Yeah, I mean, we are very much, especially at WashU, all the people that I work with know that we are very committed to biomarkers. So I would be clearly in the biomarker camp, and you know, we've provided a number of smaller studies to show that those biomarkers are useful and they are more sensitive than an EF measurement. So we feel like we've shown this, maybe not in every clinical situation and every particular cancer therapy, but certainly in the higher risks ones, I feel that the evidence is pretty strong. Now, if you're used to cardiology standards, you know, you need to have a 10,000 person study that was randomized across the world, et cetera, et cetera. I don't think that's going to happen. So in the absence of some massive randomized study, I think that the evidence is pretty strong, but that's my opinion.
So it's Joe, I agree. I think that the most valuable negative predictive test that you can get is a normal biomarker.
And then, of course, Joe knows that I can't let this one sit, but the slide you showed about type 1 versus type 2, I can't let that one go. Okay? If you simplify all of cancer therapy and the range of cardiovascular toxicity to 2 types, I think that is far too simplistic. I think if you're talking about these 2 drugs and, you know, this is all you want to talk about, then this version is okay. But the complexity of cancer therapy has gone so far past this that, you know, tell me what, you know, myocarditis related to a checkpoint inhibitor, is that type 1 or type 2 or type 3 or 4 or 5 or type 55? What type is that one?
No, you're absolutely right. I think, as you say, this is probably only relevant to this particular context, and really just to illustrate the distinction between the 2 therapies as far as we know it. But I think you're completely right that in the broader scheme of things, there are so many different toxicities, and not just myocardial either. I think there are, you know, rhythm toxicities. There's a whole lot of other issues, coronary toxicities, and so you sort of can't sort of artificially box them into just these 2 categories for sure.
Yeah.
Yeah. So parenthetically, I've been biopsied and I have a vacuole in my heart, and it says Dan Lenahan. And when I saw this slide, I got chest pain.
I'd like to make a comment, if you can hear me. 2 things you said were really, Ron, 2 things you said that were really resonating with me. One was the need to continue treatment. There was a study by Doug Mann in mice, which was really quite interesting, where he caused heart failure primarily by occluding the aorta, or, you know, closing the aorta in mice, and developed heart failure, then let them recover, and then tested it again. And the mice that had recovered were very sensitive to a second stress. And I think that part of what we're seeing is that the hearts never totally recover, but you're able to control their afterload and other features that make them look like they're doing fine until they get stressed again. And I think that is always in the background, and I think it supports the idea of continuing therapy. And the other thing that that I'd like to say, which sort of reinforces the use of biomarkers. And of course, I've been exposed to Dan and his evangelism on biomarkers. I totally agree. And that is that the ejection fraction is got a range. It's not a precise number. And we're doing a study now on sarcoma patients where we're having echocardiograms read by several operators, experienced operators, and the results will vary. And so if you draw a fine line and say anything below that line is bad and anything above that line is good, it's wrong. So you need some corroboration, and that's, I think, where biomarkers are very important. And if you just look at ejection fraction, you're going to probably, I think, prematurely stop therapy unless you have some corroboration with the biomarkers and perhaps even with symptoms. I mean, one problem with symptoms is that they reflect not only reduced ejection fraction, reduced systolic function, but also diastolic function. And so the same symptoms can present, and it may be diastolic heart failure unrelated to perhaps to the chemotherapy, and yet it can confuse your management. So I think that all of these things need to be considered more than just an ejection fraction. I really appreciated this presentation. I thought it was excellent.
Oh, thank you for that. I wonder if I could ask you or folks on the call, I mean, this COVID-19 really brought biomarkers to the fore in our group. We had been a very imaging heavy group, but we really asked ourselves, could we go to a strategy of biomarker monitoring as your first line to detect cardiotoxicity and do away with the imaging so that, you know, technicians and patients weren't exposed to risk coming into the hospital? Is that a strategy that folks are employing at all or have employed, especially in the pandemic?
Yeah, we're firm believers in that strategy, and actually ICOS put together a COVID-related cardio-oncology document, and that was a big part of the message. So we very much are in favor of that strategy, and I think, as Joe said, if you have negative biomarkers, the chance that you have any important cardiovascular manifestations are really low. It's almost zero, and so I think that it's the subtleties come in when the biomarkers are abnormal. Then what do you do type thing. But if you have negative biomarkers, you can be assured that there are no major cardiovascular events occurring. But the other point that I would make, you know, and you talked about continuing on in the face of LV dysfunction. And I think you showed the Safe Heart study, and then of course you showed your study. I would say there has to be at least 2 or 3 major qualifiers to that statement. So first off is heart failure is not a joke. And if you look at the data that you showed about, you know, only 2% had heart failure in that large randomized study with Dennis Lehman as the first author, you know, only 2% had clinical heart failure, but that's heart failure that got admitted to the hospital. And then what are we doing? We're trying to deal with them on an advanced heart failure level. So these people are in serious trouble. So 2%, that's a pretty high number when you're talking about serious heart failure. And if you talk about the development of heart failure, or you're beginning to show signs of heart failure, that could be a reduction in your EF. In that same population, it was 18.6%, so 1 in 5. So does that mean you're going to close your eyes until they develop severe heart failure? Or are you using the EF to give you a window into those people that are developing heart failure? And the key to me is it's not so much whether you detect the development of heart failure, it's whether you treat it appropriately. It's whether you put them on maximal cardioprotective medicines. Then I do think you can continue on therapy. But if you don't treat that heart failure, you are asking for a really big problem.
Absolutely. No, that's a
And
really
that's where the
valuable point.
biomarkers, I would say that that's where the biomarkers would come in handy, because there's this concept about hemodynamic congestion, which usually precedes a drop in ejection fraction. So a patient who has an elevated BMP is telling you something specifically if it's pretty high. So in those patients, even if the ejection fraction hasn't dropped significantly, you should be aiming to some extent your heart failure therapy to try to reduce that number, the BMP value, as much as you can, ideally below 1,000 or 1,500, which is what has been previously reported. Also, I think that we need to start moving, not necessarily moving away completely, but at least adding the value of understanding the cardiac remodeling in the context of an ejection fraction. So, identifying when patients are starting to have a little dilation of the LV, even if the ejection fraction hasn't dropped dramatically, it's something really important. And I was actually waiting to hear the case that you were going to mention about the patient who had exactly the same ejection fraction, but already had significant mitral regurgitation, which would suggest that there's significant cardiac remodeling. So I think that that's going to be particularly important, recognizing LV dimensions and things like that in the context of abnormal biomarkers.
Yeah, I agree.
I would also add that we did publish an updated guidelines type statement in Annals of Oncology in February of this year, and in it was a central figure that talks about EF change and at a certain level, but then also really focuses on using cardiac biomarkers, but then even more importantly, cardioprotective therapy. So that's the whole paradigm of checking the EF is one thing, but it's really about following biomarkers and using cardioprotective therapy to its maximal level to allow that patient to continue on treatment. So I think that's the real important general change in these guidelines. And so I think the other thing that's misleading about the slide you have shown right here is it says no cardiac death. But the follow-up was only 4 years in that study. And I mean, many patients who develop heart failure, they may die a number of years later, primarily a cardiac death. But it's not going to be within a 4-year follow-up period. So I think that attributing a cardiac death to chemotherapy is hard to do because the follow-up for chemotherapy is only a matter of years.
I think those are fair points, and I guess speaking with folks, I'd be interested in the proportion on the call here, but there are quite a lot of groups that will adopt this approach of maximizing heart failure therapies and continuing with Herceptin when the EF is in that 40 to 50% sort of range. But while we offer it to folks at our institution, I do have significant concerns, as you allude to, about the longer term implications of that. And as you say, heart failure is not something that we should take lightly, and a 10% incidence of clinical heart failure or profound fall in ejection fraction is too high in my mind to be able to make this standard of care. And so that's why I feel that clearly a randomized trial is necessary, although it will be difficult to pull off to try and address it. But I'm interested in people's comments and attitudes about continuing on Herceptin in light of these kinds of data.
Yeah, I would be much more cautious in general, because I agree with you 100%. Everything you just said, I'm totally on board with, because I have seen those patients who are waiting for a VAD or transplant that got chemotherapy years ago and it was just basically ignored or it wasn't screened. And so I think that, it's a serious problem. And I think that if your EF is in the 40s, you're probably okay, but you need to watch very carefully, and that's where it's especially important, where I feel biomarkers are a big part of that. But I think if it starts to progress, you know, you have to discontinue therapy right away. You cannot keep going.
Hi guys, this is Geeta from Norway. Thank you for a great talk. I would say that here in Oslo, we are, in light of these studies, actually continuing Herceptin in patients who have a drop in their ejection fraction, but we monitor them very carefully and very often, of course, and then we start them on angiotensin inhibitors and beta blockers. And the few patients that I've had so far, it's worked quite well, but of course we need to see how it goes in the future. And I also wanted to comment on the following up with biomarkers. I think biomarkers are great, but I was just wondering that they wouldn't really be able to perhaps detect the early subclinical left ventricular dysfunction, perhaps in patients who would benefit from cardiovascular protection early. So that's my comments.
Yeah, no, I think I'm sure there's lots of interpretations of how, you know, the current data that we have and how we want to modify that to our own individual practice. I think that the key element is to not just to detect the problem, but to treat it. So I would say it's one thing to find a change in EF or a change in strain or a change in biomarker. What's much more important is to treat the LV dysfunction in an optimal fashion.
I agree.
So this is Joe. Darryl, this was an excellent presentation and discussion. There are two things that I'd like to highlight. The first is your case 3, and that just because people are getting chemotherapy doesn't mean that everything that happens is due to the chemotherapy. So we should keep that in mind, and that's really an important point that you made. And then the other is that we've been basically talking about adjuvant chemotherapy, and I think there's a whole different discussion when you're talking about continuing Trastuzumab and other HER2 inhibitors in patients with metastatic disease. And there, I at least have a much more liberal tolerance of drops in EF and changes even in biomarkers when it's a critical issue in keeping people alive from their cancer.
I think it's a great comment, and you're very right there. We adopt the same approach for metastatics as well. Absolutely.
Now, and Darryl, I really applaud your efforts to do a randomized study. I think that is so important, and even if it's a small study, but you're careful and you're disciplined in how you do it, then it will be extremely informative for us all. So yeah, I think it's really wonderful. I'm so glad you've been pursuing that, and looks like despite lots of challenges, you have a very real possibility of completing it. So congratulations on that.
No, thank you. And we do have a great collaborative network in Canada, but we would also be interested in folks, if you're not in Canada as well, if this is of interest to you to participate, we'd certainly be happy to explore regulatory challenges and whether or not it's feasible in different countries and environments, because I think the more data we can collect to understand this idea of continuing Herceptin, the better informed we're going to be when we're speaking with these patients.
Yeah, so you can mark us down at WashU in St. Louis for we'd be happy to see if we can overcome those things, and at a minimum we'll do the same study you're doing.
Terrific. Well, that would be wonderful. Appreciate that.
All right, well, I guess nobody else has any comments. You really brought up a lot of bread and butter essential questions that we have to deal with frequently. And I think, you know, your presentation was really excellent. So we appreciate that that you're doing what you're doing and that you were willing to share it.
No, once again, thank you for inviting me. I mean, I think this is a terrific forum to be able to share ideas in this sort of growing area, and really appreciate the comments and feedback and thoughts. I think it's a brilliant forum. So thanks very much.
All right. Well, Steve, do you have any closing comments on things?
Just to let folks know, there is another case presentation tonight at 7 p.m. Related to cardiac tumors, and then next week, same time, there'll be a COVID-related webinar, and then the following week, May 28th, there'll be a presentation on topics in cardio-oncology related hypertension with VEGF inhibition therapy.
Excellent. Well, thank you all for participating, and we'll see you soon again.
Thank you. Take care, everybody.
Thank you very much.
Thanks again, Darryl.
Thank you so much.
Take care. Bye-bye.